Hello, everyone. Welcome back to our interactive NCLEX RN review session. Now we are on day 39 of the 90 days. We are offering the different or a wide variety of nursing concepts. And so for the meantime, we are focusing on the medical surgical nursing topics. And for those who just join us, we are inviting you to enroll in our comprehensive NCLEX review course at Stancoast NCLEX Coaching, where you have access to the 3,000 NCLEX style questions, and we have on-demand videos that you can use in your downtime. And we really want to build your confidence with all the study materials that we have available in our system. Now, please don't forget to visit our website. And again, that is at www.stancoastnclexcoaching.com. And kindly check the description box below so you can go ahead and take a look into our offerings. Now, we are also encouraging you to share your thoughts, your comments, your questions in the section below, the comment section, or in the chat box, so we can happily help you with those questions. Now, I also encourage you to like and subscribe this video if you find this session helpful. And for today, we will be focusing into the topic of the platelet disorders. So let's get started. So welcome for those who just came into the classroom. We have Adiola, Milrose, Mary. All right, perfect. Let's get started with our discussion today about platelet disorders. Now, let's go into the concept of thrombocytopenia. So what is this? Well, it's basically a condition wherein there is a decrease, a significant drop in the platelet count. Now, we know that in the adults, right, we have a normal range of about 150,000 cubic millimeter to about 450,000 per cubic millimeter. So that would be our reference, okay? Reference for the platelet count. Please don't forget normal value in adults, okay? That is about 150,000 to 450,000 per cubic millimeter, okay? So if there is a significant drop in the platelets, well, there's going to be a problem with the bleeding. A patient probably would be manifesting a lot of, let's say, bruising, petechiae, or let's say hematoma. And this can possibly lead to the hypovolemia, and when the patient will end up bleeding, right? If it's not controlled. Now, let's talk about first on the etiology of a thrombocytopenia. So what causes the platelet to go down? Well, it can result from a decreased platelet production. So that is one. All right. So what could cause the decrease in the production of the platelets? Well, it could be one of the following, right? It could be leukemia. There's also aplastic anemia and myelofibrosis. And if the patient is undergoing a myelosuppressive therapy, okay? Myelosuppressants, those treatments that can cause the suppression of the bone marrow in producing the blood cells, right? Myelosuppression, maybe radiation, or some inherited disorders like Fanconi anemia, which is a rare type of anemia. And then we also have the Wiskott-Aldrich syndrome, which can lead to the low platelet count. That is letter K, Wiskott-Aldrich syndrome. And so these are the known causes in the decreased production of the platelet. Now let's move forward to the next causative or contributing factors? Well, there could be an increase in the platelet destruction. All right, so this can be caused by the following. It could be HIV, it could be hepatitis C, or it could be caused by medications. And these medications that are known to do that are, the volume is low. Let me check. I actually have my volume up. Max volume. Let me put my microphone closer. How about now? Can you hear me better? Hello. Can you hear me better this time? Hello, hello. Just checking. Can anyone confirm if my voice is, the volume is better this time? Hello. Just want to check with you. Yeah, I have my volume in max right now. Okay. Let me know if it's working or if it's not working. Now, let's proceed with the different medications that can lead to the decreased, or actually that could lead to the destruction of the platelets, right? So like I have said, it can be caused by HIV, hepatitis C, but for the medications, it can be caused by heparin therapy, which is a common medication that we'll be using in so many patients, and quinidine. So these are known medications that can increase the destruction of the platelets. All right. Now, there's also the disseminated intravascular coagulation, which is the DIC, right? But we will be talking about the DIC tomorrow, which is a separate topic because this is not really specific to the platelet dysfunction. We'll be talking about this tomorrow together with the other coagulation disorders. Now, let's review. For those contributory factors that can increase the destruction of the platelets, these are the following. We have HIV, hepatitis C, medications such as quinidine, heparin, and other conditions like disseminated intravascular intravascular coagulation. Now let's move on to the third contributory factor. This could be caused by the abnormal platelet sequestration. So what does that mean? Well, this is going to be attributed to those conditions that are affecting the spleen. All right, please don't get confused. When you encounter this term right here, abnormal platelet sequestration, these are pertaining to those disorders that can affect the spleen, wherein the platelets may be sequestered and will not readily be available for circulation. Now, another contributory factor in the thrombocytopenia is what we call as the delusional thrombocytopenia, wherein it can be caused by significant hemorrhage, or maybe, let me just write that down first, hemorrhage, or packed red blood cell transfusions, wherein the relative concentration of the platelets in circulation will decrease, right? Especially if the person will be getting a lot of packed red blood cell for their anemia, then again, the concentration of the platelets in the circulation will decrease. That's why it's referred to as delusional thrombocytopenia. Okay, now let's talk about the clinical manifestations of the thrombocytopenia. Well, the patient here sometimes can become asymptomatic, so they're not going to show any manifestations, but when it comes, when the platelet goes below that count, let's say 20,000 per cubic millimeter, if they're gonna go down to that level or less than that, then this is the time when they're gonna manifest some petechiae. There's gonna be ecchymosis or the bruising. There's probably gonna be the nose bleeding, heavy bleeding during menses. There's that menorrhagia. And in severe cases, guys, the thrombocytopenia can be manifested by even prolonged bleeding after minor procedures, or they can probably bleed into the organs. And in some cases, the thrombocytopenia itself can lead to what we call as thrombotic complications, such as in the case of heparin-induced thrombocytopenia. Okay, so I want you to pay attention regarding the HIT, or the heparin-induced thrombocytopenia, because its mechanism is somewhat kind of weird. There is now development of the antibodies in relationship or as a result to the exposure of the heparin. Okay, so we will talk more about the HIT in the next few slides. But again, the patient will manifest the following. If they're gonna be as low as 20,000 per cubic millimeter, then they're gonna manifest those petechiae, ecchymosis or the bruising. There's gonna be menorrhagia or epistaxis, and then with prolongation of the bleeding, even with minor procedures or even a paper cut. All right, so there is going to be prolonged bleeding time, and at some point, if they have some form of bleeding into the visceral organs, that can happen as well. But again, in HIT, it can lead into thrombotic complications. Even though their platelets are low, they can still develop the thrombosis. So please take note on that one. We will talk a lot more about this. Now, we will be checking into the patient's diagnostic test. So what are those tests that will help in the diagnosis of thrombocytopenia? Well, we have the complete blood count and also the platelet count, which will show a decrease in the platelets. It will be decreased, and also a possible drop or a drop in the hemoglobin because of the associated bleeding, right? And same thing with the hematocrit. These will also be decreased. So please pay attention into the CBC and platelet count. Now, we're also going to have the coagulation tests. Even though that the patient's main problem here is on the platelet itself, but the coagulation test will also be the recommended diagnostic test in order to differentiate the thrombocytopenia from other coagulation disorders like the DIC or those bleeding disorders like hemophilia A and B. And so the coagulation test really here is only to help differentiating the thrombocytopenia from other coagulation disorders. And the coagulation test here can also help in determining the prothrombin time, the activated partial thromboplastin time, and also the bleeding time, right? That would be included as well. So recalling the different values here, like the bleeding time. Do you remember the normal bleeding time? What's the normal range? All right, so the normal bleeding time ranges from about 2 to 7 minutes. Okay, in thrombocytopenia, this bleeding time will be increased. All right, exceeds 7 minutes. And this test will evaluate how well the small blood vessels, the platelets, and also the clotting factors are working to form that clot, right? Now, let's recall the prothrombin time. What can you remember about the prothrombin time, or known as the PT? It ranges about 11 to 13.5 seconds. Okay, maybe in some books it will say 11 to 15 seconds. There will be some slight variations. Okay, the APTT will also be tested. Okay, so which is the activated partial thromboplastin time. which is going to range from about 25 to 35 seconds. And again, the values that you probably know will be slightly different from what I have. Yeah, that is expected, guys, according to the laboratory that's been used, or yeah, as a reference value. And with the PTT, or the activated partial thromboplastin time, this can also vary, like I've said. Now, another testing that will be done in order to help in the diagnosis of thrombocytopenia is what we call as the platelet aggregation test. And this is going to be helpful in determining the heparin-induced thrombocytopenia. Okay, so this is specific to the HIT, platelet aggregation test. All right, so please don't forget. Oh, I'm supposed to put here diagnostic test. I did not change it. So these are the diagnostic tests. Let me just quickly change that. Hang on a sec. All right, 4646. Diagnostic test. Here you go. Oh, were you even seeing the screen? No, I didn't. Okay, so here we go, diagnostic tests. All right. So here are the tests that will help evaluate the thrombocytopenia, okay? CBC with platelet count, coagulation test, and platelet aggregation test for the heparin-induced thrombocytopenia. Now, we'll talk about the management. Again, welcome for those who just came into the class. Welcome to our session today. We're talking about platelet disorders. Now, how is the thrombocytopenia managed? Now, let's start with the steroids. Basically, one of the modalities here is the administration of the steroids, specifically the prednisone. Okay, so this is a very common treatment that will manage the thrombocytopenia. So this is going to be useful in immune-mediated type of thrombocytopenia, steroid, okay? So this is going to be useful in treatment of the idiopathic thrombocytopenic purpura, or known as the immunothrombocytopenic purpura, ITP. Now, another treatment modality here is the administration of the IVIG, the IV immunoglobulins, which is going to mitigate the immune-related thrombocytopenia. Okay, immunoglobulin. Now, there's also splenectomy, which is that surgical procedure in such cases of ITP in order to remove the site of the platelet destruction. Okay, now there's also the administration of thrombopoietin receptor agonists. So these are medications that can stimulate platelet production. They're going to stimulate platelet production. And some of the medications that are known to increase the platelet production is what we call as romiflostin. It's a very rare medication, romiflostin. I don't know if you've heard about this medication. The brand is Nplate. So kindly look this up on your downtime. And this is going to be administered as a subcutaneous injection. All right, subcutaneous injection, which will be given once a week, or it could be 2 times every 2 weeks, or once every 2 weeks rather. Let me erase that. Once every 2 weeks. So again, that is the romiplostim or the N-plate, N-P-L-A-T-E. Now, another known thrombopoietin receptor agonist, rather, that is the L-thrombopag. L-thrombopag, and the brand name is Promacta, spelled as Promacta, and this is going to be taken as a tablet, which is going to be taken once a day. And it will stimulate the production of the platelet by binding and activating the thrombopoietin receptor. So it will bind to the thrombopoietin receptor. So it will bind and then activate the thrombopoietin receptor, and thus it will now stimulate the production of platelets. Okay, so please don't forget about the medications Promacta and Plate. So these are medications to help produce more platelets by activating the receptors, the thrombopoietin receptor. Now, guys, please take note about the management here. I want you to focus in the next management here because this is going to be specific to the heparin-induced thrombocytopenia. So I know that you probably would think, hey, my patient with the heparin-induced thrombocytopenia probably could benefit in the platelet transfusion, but that is actually wrong, okay? When we are dealing with a patient with the HIT, there's going to be avoidance of platelet transfusion because the disorder itself is actually going to complicate into thrombotic episodes. And we don't want to cause more problem in this patient with the thrombocytopenia caused by the heparin. Okay, this is going to lead to what? Thrombotic complications. And we should not be administering platelets. Thrombotic complications. So the more that you're going to be giving platelet transfusion this time, it will worsen the condition, okay? So we're going to do something else instead in treating the thrombocytopenia, okay? We'll be talking a bit more on that later on as well. Now, the reason on the avoidance of the platelet, reasons of avoiding platelet transfusion, we have several. Okay, one is that the HIT itself, the heparin-induced thrombocytopenia, is caused by the formation of antibodies. Okay, so that's one reason. Formation of antibodies against the exposure, right? Once it was exposed to the heparin, it will now form the antibodies that will now activate the platelets. So the formation of antibodies will activate the platelets. And when this happens, this can lead to that increased thrombotic risks. Okay, instead that they're going to bleed, they're going to be thrombosis. Now, if we're going to transfuse the patient with the platelets, then this can exacerbate the thrombotic risk. We don't want that, guys. Okay? Now, the other reason of avoiding the platelet transfusion in thrombocytopenia caused by heparin, again, this is about the heparin, it will be ineffective. Why? Because the platelet transfusion will, again, this is not going to work against the bleeding, okay? Because remember about the thrombotic episodes that will be increased with the formation of the antibodies? Well, it will now continue to cause the destruction of both the transfused and also endogenous platelets, okay? It becomes ineffective because the antibodies will further destroy. Let me just put here, further destruction of transfused platelets. So it's not really going to work for this HIT. Let me erase this. There's just so much writing here. And again, like I've said earlier, with the activation of the platelets from the antibodies, this can lead into what? Thrombotic episodes. So again, if we are going to add more platelet into the body because we are thinking, hey, maybe this would help stop the bleeding. But again, no. The more that we are adding platelets into their system, the more that the antibodies will further destroy the transfused blood product, the platelets, and also the endogenous platelets. So we are not going to do that, okay? So what would be the treatment here, guys? We are going to focus on treating the underlying cause, which is to basically stop the heparin infusion. So let me clear this. We are going to stop the heparin infusion. If the patient has been prescribed the heparin infusion, maybe because of a DVT issue, and then they went into a complication such as the HIT, so definitely we're going to have to stop infusion in this patient. Stop heparin infusion. Stat. Okay, that would be the main action here, guys, when we are suspecting that there is HIT going on. Again, we will know this by a drop in the patient's platelet count. All right. Now, we're also going to be administering the medications that will be prescribed by the medical provider as an alternative anticoagulation therapy in order to prevent the exacerbation of the HIT. Now let's move on to the nursing actions that will be very crucial in treating the thrombocytopenia of the patient, and this will also include the HIT. So what do we do here? We're gonna have to assess the patient for the underlying cause of the bleeding episode. We're also going to evaluate the current medication, identify the cause. We're also going to review the medications. What are those active prescriptions the client is taking? Is it the anticoagulant heparin, or are they taking any over-the-counter medications like those herbs that are known to have anticoagulant effects, like the ginkgo, garlic, ginger? So we need to investigate further about that contributory factor, and also possibly any exposure to other factors, right? Now, after we're going to do the assessment, we're going to need to institute the bleeding precautions. And this may sound repetitive to you, but this is very important in the treatment of thrombocytopenia. So what are we going to do? We're going to have to implement strict protocols to minimize the bleeding risk. So what would be those interventions? We're going to have to minimize invasive procedures like unnecessary venipunctures, right? Minimize invasive procedures if unnecessary. That would be one. And then we're also going to have the patient use those soft bristled toothbrush, soft bristled brush, the use of electric shaver instead of having them use the straight razor. That's one. And also we're going to have to assess, or from time to time, we need to evaluate for any signs of bleeding. Okay, so what would be those signs of bleeding? check for manifestations of bleeding, such as the hematoma, gum bleeding, epistaxis, could be the blood coming out from the urine or stools. Then those are the things that we should be doing. Now, part of the intervention here, guys, or the nursing actions would be to monitor for any complications, more signs and symptoms, and we're going to have to educate the patient for those steps that they should be reporting to the doctor, especially if they're going to capture any of those manifestations. Yeah, avoid flossing teeth. That's another one. No flossing of teeth. Because this can aggravate. No flossing. All right. And so with the patient education, it's very important, guys, that you are going to extensively educate them about those important bleeding signs, and so that they can report this to the medical provider and make sure that they're going to be attentive to their regular follow-up to make sure that their platelet counts are checked periodically. Okay, so make sure they're going to have to watch for the signs and symptoms of bleeding. What else? We want to make sure that they will be compliant with the follow-up. Compliance, I should say. Compliance to follow-ups. To follow-up appointments and lab testing, such as the platelet count, or it could be the CBC. Hello, good morning or good evening, wherever you're from. For those who just join us, welcome to our classroom. All right. Now again, guys, we are reminding you to enroll in our review program for the NCLEX at www.stancoast.nclexcoaching.com. You will be able to access our materials there. We have 3,000 NCLEX questions. We have our NGN test questions of about 200 plus. We also have our recorded videos available, and also that animated videos for your downtime, which you can use anytime 24/7. And again, this subscription will be good for about 6 months. So make sure that you drop by and visit our website at www.stancoast.nclexcoaching.com. All right. Now, we're also going to talk about another problem here, another issue in the platelet, which is what we refer to as the idiopathic thrombocytopenic purpura. And again, this is a bleeding disorder that is caused by the immune system. Immune system disorder. Immune system disorder, which will actually attack the platelets through the antiplatelet antibodies. Again, the idiopathic thrombocytopenic purpura, or known as the ITP, is a bleeding disorder that is caused by the immune system that will end up attacking the platelets through the antiplatelet antibodies. Okay. So these are actually very interesting topics today, most often caused by the immune system dysfunction. Now, as far as the pathophysiology with ITP, this is going to be caused by the platelet protein surfaces that is going to trigger the autoantibodies. Again, the pathophysiology about the ITP starts with the proteins on the surface of the platelets. This will now trigger the autoantibodies, which will bind into the circulating platelets. Okay, will bind to the platelets, and then this will now cause the destruction of the platelets. Guys, we're talking about the ITP this time. And the destruction will occur primarily in the spleen and liver. So these are the specific sites where the platelets are going to be attacked. Okay, so the proteins in the platelet surface proteins will now what? Trigger the autoantibodies, and then this will end up binding into the platelets, which will now cause their destruction. Now, in some cases, guys, with the ITP, let me get rid of that. In some cases, especially in children, it will follow after a viral infections, but somehow will resolve after 6 months or within 6 months. Now, in chronic cases, this is going to be a little bit different, especially in women. They are identified to have more occurrences of the ITP, and it usually will occur in ages 20 to 50 years old. And predominantly, again, this can occur in women. Now, some of the associated disorders that will lead to the ITP are the following, such as the SLE, which is the systemic lupus erythematosus, which is actually an autoimmune disease, right? And so this will now lead to the attack of the healthy tissues. And also, in some cases, the autoimmune response can also attack the platelets, thereby destroying the circulating platelets. All right. Now, another problem that is associated with ITP is the thyroid disorders. So either the hypothyroidism or it could be the hyperthyroidism. This can also influence the immune system. Now, in the autoimmune type of the thyroid disorders, this is commonly referred to as the Hashimoto's, right? So this is an autoimmune type of thyroid problem. The immune response here can target the platelets. Targets the platelets. All right. And in some cases, such as an infection like the Helicobacter pylori or the H. pylori, this is going to affect some individuals and can also trigger immune responses. Okay. Triggers immune responses. H. pylori, are you familiar with that bacterial infection inside the stomach? It can trigger immune responses that can react with the platelets. And so it can actually result in the immune system attacking both the bacteria and the platelets. Okay? It can trigger responses which will eventually attack the bacteria, but not just that, it can also attack the platelets, which will eventually lead to the thrombocytopenia. So this is something that you should recall. H. pylori infection can trigger responses that will cause attack to the bacteria, the H. pylori, but it will also attack the platelets, causing its destruction. Now, another condition is the hepatitis C. What do you think about the relationship or association of hepatitis C and the ITP? Well, with hepatitis C, which is a chronic liver inflammation, this can lead into the production of autoantibodies as well. Autoantibodies, which can also cause the destruction of the platelets. All right. Now, another is the HIV, human immunodeficiency virus, which can also affect the immune system in so many ways. And one of the mechanisms that is involved here is the autoantibodies that will attack the platelets, just like similar to the hepatitis C kind of a mechanism. And then we also have the chronic lymphocytic leukemia, or known as the CLL. Okay, so what is this CLL? This is basically abnormal lymphocytes, abnormal white blood cell production. So this is going to accumulate in the bone marrow. Accumulation of abnormal white blood cells in the bone marrow. And so when these abnormal cells are going to accumulate there, it can now produce the antibodies as well. Produce antibodies that will also target the platelet. Platelet destruction. I know the pathophysiology of each disorder here is quite long. I'm trying to shorten them. So in order for you to really understand the association between these autoimmune disorders with the ITP. Now, guys, I hope that you're able to capture all these concepts. These are the immune disorders, SLE, thyroid disorders like the Hashimoto's. Oh, I forget the Graves' disease. Hashimoto's and also the Graves' disease. That's another one. And then the H. pylori infection, which can cause the development of those triggering systems, which can attack the bacteria and also attacking the platelet circulating in the body. Now, we will be talking about the clinical features. What are those manifestations that you will be seeing in a patient with ITP? Well, those manifestations can vary as well. It can be asymptomatic for those patients in mild cases. However, if the platelet count drops 30,000 per cubic millimeter, then this is the time that they're going to manifest those bruises like the petechiae, the ecchymosis, or maybe the gum bleeding or epistaxis, or let's say heavy menstrual bleeding. So these are the common manifestations in a patient having the ITP or the idiopathic thrombocytopenic purpura. Now let's move on, guys, with your favorite this time, the diagnostic test. What do you think would be those diagnostic tests or even laboratories that will aid the medical provider in establishing the diagnosis? Well, one of those is the complete blood count, of course, with a platelet. And so if there is a drop of the platelet count less than 100,000 per cubic millimeter, this is already considered as the incidence of the ITP. And another thing is we're going to have to anticipate testing our patient for those infections. Let's say, for example, hepatitis C, or the H. pylori, or the Epstein-Barr virus, which I forgot to include in the previous slide. But we're going to expect the following testing to identify if there's really an H. pylori infection, or the Epstein-Barr virus, or the hepatitis C. We're going to make sure that we have that on board. Again, that is the hepatitis C virus testing. Now, another test that will help in the diagnosis is the bone marrow aspiration. This is a very invasive procedure done in a surgical setting, okay? This can reveal the excess immature platelet forming cells, okay? So the bone marrow aspiration will what? It can reveal excess megakaryocytes. Excess megakaryocytes, or those immature platelet forming cells. Immature platelet forming cells. So they're going to be excess in the circulation and also will be detected by the test. All right. Another testing that will help in the diagnosis of ITP, since this is an autoimmune problem, will be the detection of the platelet autoantibodies. So this will confirm the diagnosis of ITP. Platelet autoantibodies. Let me correct that. Or basically, that's quite the same. And we're also going to check on the bleeding times, which will usually be about normal, even though the platelet counts will be low. So that's kind of weird here. The bleeding times will probably be elevated, or it can be normal in some condition. Now, we will be talking about the treatment of the ITP. What do you think would be those treatment or management? Well, one of those is the platelet transfusions. Guys, this is now different. We are talking about ITP. We're not talking about the HIT. Earlier, we're not supposed to transfuse platelets in HIT, but this time in ITP, the transfusion of platelet is very important in order to replace the lost platelets, okay, and also will increase the patient's platelet count rapidly. This is very important, okay? So, to replace platelets in a rapid manner. Now, another is to control the bleeding. How are we going to control the bleeding? There's many steps to control the bleeding. So possibly local measures, right? Like we're probably going to have to apply pressure to the bleeding site. We're also going to have to prevent those or avoid doing those invasive procedures if unnecessary venipunctures. So we're not going to cause some more bleeding into the system. Another is to observe those bleeding prevention methods, like we had mentioned earlier about not using the straight razor. We want to make sure that we're gonna what else? Straight razor, no flossing their teeth. They're gonna have to be using the soft bristled brush to prevent the aggravation of the bleeding, right? So those are the measures that we will be implementing in our patient. Another treatment here is the administration of the high-dose corticosteroids. And what are these steroids? Well, we are going to expect the prednisone or the dexamethasone. And the reason that they're going to be helpful is that they're going to suppress the immune system response. They're going to suppress the immune system response. So this will now decrease the destruction of the platelets caused by the immune system dysfunction. All right, so we're going to expect high-dose steroids. Another is we're going to have to administer the IVIG, which is the intravenous immunoglobulin G. And this is going to contain purified antibodies. IVIG actually is such like a wonderful treatment. I've performed so many of the IVIG therapies on patients with myasthenia, which will require one-to-one observation because this is a very risky procedure. Patients can actually develop anaphylaxis, so it will require one-to-one care during the infusion. Up until it's completed, you really need to do a lot of monitoring, and this is going to be done. It can be done in the medical surgical setting, which I've done quite several times already. And so again, with the IVIG, the treatment itself can help block the antibodies. It will block the antibodies that are responsible for destroying, block the antibodies responsible for attacking the platelets. So that is the reason why IVIG treatment is effective in managing the ITP. Again, it will block the antibodies responsible for destroying the platelets. Now, the IVIG therapy is going to be done once the high-dose corticosteroids are not that effective in treating the ITP, okay? So again, the IVIG is going to be done if the high-dose corticosteroids are ineffective or is not tolerated by the patient. Now, another therapy that you need to know is, let me erase this. That is the anti-D immunoglobulin. So what is the anti-D immunoglobulin? This is going to be beneficial for those patients that are Rh positive individuals with spleen. So this is basically going to work by suppressing the immune response. Suppresses immune response against the Rh positive platelets. Again, the reason for the anti-D immunoglobulin is to suppress the immune response against the Rh positive platelets, which can occur in the ITP. Now, another management here is the administration of, or let's say the splenectomy, I should say, let's not forget that, which is going to be used, especially when there are many platelets that have been like widely destroyed inside the body. And so the removal of the spleen or the splenectomy itself can reduce the destruction of the platelets. Okay? Reduces destruction of platelets. So that's the reason why the splenectomy can help the patient in a case of ITP. Now let's go back to the thrombopoietin receptor antagonist, or agonist rather. We talk about this one when we dealt with thrombocytopenia earlier. And so we have the medications, the Promacta, we have the Nplate. So these medications basically will what? Trigger. They are going to stimulate the thrombopoietin receptors in order to produce more platelets. Again, they are going to stimulate the thrombopoietin receptors. Thrombopoietin receptors in order to cause production of platelets. All right, so I've mentioned about this earlier. Some of the medications here is in the form of subcutaneous injection, and the other one is the oral form, which the patient will be taking in daily basis. Now let's talk about the nursing actions that will be needed for this patient with an ITP. So again, we will start with the assessment. We're going to make sure that we are thoroughly investigating the patient's medical history. We need to have at least a complete medical history of our patient. Past and present would be beneficial here. Past and present history. And also their chief complaint. We need to determine if they had any episodes of bleeding, right? Of course, they're going to come into the hospital because of the bleeding, but we're going to ask them how severe the bleeding has been. Let's say the petechiae, the ecchymosis, the heavy menstrual bleeding, and also the incidence of the bruising. Are they just bruising spontaneously? Okay, so make sure that you're gonna ask thoroughly this kind of conditions to your patient. Another thing, we're gonna have to conduct that physical examination, of course. Make sure that you do your skin assessment carefully. Symptom review, that would be also important. Now, for the nursing care, we definitely need to minimize the incidence of bleeding. We're gonna have to do our nursing precautions, strict bleeding precautions. We're gonna have to monitor their patient's menstrual flow, also possibly the administration of the blood products, right? Blood transfusion would be another one. It could be the platelet transfusion, or it could be the packed red blood cell transfusion if they are now anemic. If there is a significant drop in their hemoglobin, let's say if it's less than 7 grams per DL in their hemoglobin. If there is obvious hemorrhage, well, of course, they're going to need the blood transfusion with the packed red blood cells. And also, if their platelet count drop below the 30,000 level. So definitely make sure you are ready about these kind of nursing therapies. Now, another is to patient education is very important here. We're going to have to teach the patient about the symptoms that they need to report to the medical provider when they're at home. We're going to need to teach them about the prevention of bleeding, right? We're also going to have to demonstrate to them proper wound care techniques, maybe if the patient has a pre-existing wound, and make sure that we are also stressing the importance of their compliance to the follow-up visits, especially when they're needing to be checked for their complete blood count, right? Or platelet monitoring. Cerebral bleeding, that can be possible, Roxanne. Yes. So I haven't included that one yet because this will come as a surprise in your test. No, I'm just kidding. Actually, it will be one of the manifestations, but I just didn't include it yet. It will be included in our follow-up test items. Okay, let's get started, guys, with our exercises. Here we go. Question number 1. An RN is asking a nursing student about their understanding of the causes of thrombocytopenia. Which of the following statements made by the student reflect understanding and no understanding about the disease process? Okay. The items involved here are the following. Thrombocytopenia can be caused by bone marrow failure due to aplastic anemia. Number 2, tumors and leukemia can lead to decreased platelet production by invading the bone marrow. 3, excessive production of platelets can cause thrombocytopenia. 4, infection and radiation can cause injury to the bone marrow, leading to thrombocytopenia. 5, delusional thrombocytopenia can occur after transfusions or hemorrhage. And 6, thrombocytopenia can be caused by increased platelet production due to immune responses. And 7, sequestration of platelets from splenomegaly can result in thrombocytopenia. And D, thrombocytopenia cannot occur during pregnancy. All right, enjoy the statements here, and I want you to identify if the statement reflects understanding, I just put you there, or NU, no understanding. All right, take your time. Great. For those who just came into the classroom, welcome to our session. We are doing this for 90 days for free. So invite your friends who are preparing for the NCLEX. We are going to do some more of lectures live every 9 p.m. daily Eastern Standard Time. So make sure that you're sharing this video and also subscribe, and don't forget to give us a thumbs up. All right. Guys, where are your answers? I'm waiting for your answers right now. I thought that you were excited to answer this type of questions. Oh, there you go. There's AGI TV. So what do you mean about the 1, 2, 4, 6, 7? Are you, do you mean that these items are reflecting understanding? Or do you mean that these items are reflecting no understanding about the disease process? All right, we have from Mary, 1 reflects understanding, 2 understanding, 3 no understanding, 4 understanding, 5 no understanding, 6 understanding, 7 same thing with number 8. Okay, let's go through the selections here, or the items rather. For number 1, thrombocytopenia can be caused by bone marrow failure to aplastic anemia. What does that mean? Is there understanding? No problems. Just want to check with you. Okay, so what does number 1 mean? Does it reflect understanding about the disease process? because the question basically asks you to check if the student's statements reflect either understanding or no understanding. Okay, so number 1, thrombocytopenia can be caused by bone marrow failure due to aplastic anemia. Well, the explanation about that is the aplastic anemia, okay, is a condition where the bone marrow will fail to produce enough blood cells, including the platelets, okay? So, all right, bone marrow failure basically refers to the aplastic anemia, wherein they're going to fail to produce the blood cells, including the platelets, and it will eventually decrease the platelet count. And so, again, what you're going to see is a drop in the platelet count. And so, bone marrow failure itself is going to be one of the causes of thrombocytopenia. All right, so that would be you, understanding. Again, bone marrow failure is what we refer to as the aplastic anemia. It can reveal suppression of those blood cells, the white blood cells, the red blood cells, and the platelet. Okay, there is bone marrow failure to produce those elements. Now, what about number 2? Tumors and leukemia can lead to decreased platelet production by invading the bone marrow. What do you think about that? Number 2, tumors and leukemia can lead to decreased platelet production by invading the bone marrow. Yes, that reflects understanding. And the reason for that is because the tumors and leukemia can invade the bone marrow and they can disrupt the normal function. And this will lead to the decreased production of the platelets. And so the invasion itself by the tumors can decrease the ability of the bone marrow to produce those platelets. Okay, so it will lead to thrombocytopenia. Okay, so that is you. What about number 3? Excessive production of platelets can cause thrombocytopenia. Again, excessive production of platelets can cause thrombocytopenia. Does that mean the student understand or no understanding? Well, apparently that is false. So that will be marked as NU, no understanding. This is incorrect. Okay. Instead, that there is thrombocytopenia, there will be thrombocytosis. Okay, so that is the exact opposite. Now, what about number 4? Infection and radiation can cause, what was that? Can cause injury to the bone marrow, leading to thrombocytopenia. Let me reread. Infection and radiation can cause injury to the bone marrow, leading to thrombocytopenia. Remember what I said earlier about the radiation exposure? So here, infection, or both the infection and radiation, can actually damage the bone marrow. So it will also reduce the platelet production. Reduces platelet production. All right, so this is reflecting understanding. What about number 5? Dilutional thrombocytopenia can occur after transfusions or hemorrhage. Let me read that. Dilutional thrombocytopenia can occur after transfusions or hemorrhage. Remember about what I said earlier? If there would be massive packed red blood cell transfusion, it can decrease the concentration of the platelets in the bloodstream. So this is what we refer to as dilutional thrombocytopenia. So this will reflect understanding. Okay? What about number 6? Thrombocytopenia can be caused by increased platelet production due to immune responses. Is that correct? Again, number 6. Thrombocytopenia can be caused by increased platelet production due to immune responses. That is going to be marked as no understanding. This statement is incorrect. Whoops. This is incorrect because, as we know, if there is increased platelet production, it is not associated with thrombocytopenia, but what? Thrombocytosis. All right. Now, number 7. Sequestration of platelets from splenomegaly can result in thrombocytopenia. The trapping of the platelets in the spleen. So what does that mean? Well, when there is sequestration of the platelets, this will reduce the circulating number of the platelets in the blood, and thus will result to the thrombocytopenia. Okay, so this will reflect understanding. Number 8, thrombocytopenia cannot occur during pregnancy. Okay, thrombocytopenia cannot occur during pregnancy. Is that correct or incorrect? Well, that is incorrect. It can happen during pregnancy. This one makes that statement false. It can. Thrombocytopenia can occur in pregnancy, especially during the 3rd trimester. Okay, so take note about that. And it could be associated with the HELLP syndrome. Are you familiar with the HELLP syndrome? Yeah, we're not going to talk more about the HELLP syndrome today, but this is going to occur in the 3rd trimester. And so it will be marked as no understanding. Okay. How do you find this test items, guys? Or this test item, rather? Is it helping you kind of differentiate the different causes? Just make sure that you're able to decipher, hey, this is really a cause for the thrombocytopenia. Hey, this is not the cause. Is it helping, guys, or no? Because if it's not, then I'm not gonna make any more of these type of questions. No, just kidding. Thank God I did well today. Well, congratulations, AJI TV. Very good. Well, there's more. Let's move into the test item number 2. Here you go. Question number 2. A registered nurse is assessing a patient with thrombocytopenia. The RN must determine whether the following manifestations are expected or not expected in this condition. Glad to hear. Thank you. The question states, sour and salty, welcome to the classroom. This is the first time I've seen your name, so welcome. Mimune Costume, welcome. Thank you. Question number 2. A registered nurse is assessing a patient with thrombocytopenia. The RN must determine whether the following manifestations are expected or not expected in this condition. Now, the guys, you got to be careful in choosing the following assessment findings, because not all the bleeding signs can be directly associated with the regular thrombocytopenia. Okay, so I want you to be careful here in answering whether it's expected or not expected. Again, not all bleeding signs can be associated with the thrombocytopenia. All right, some of these bleeding signs and symptoms can be associated with something else. So make sure that you are careful in answering. Thank you. Algorithm, yeah. All right, I'm waiting for your answers. The question stated, a registered nurse, number 8 option. Which number? Is it this question, or are you referring to question number 1? Okay, let me know your answer here, Adiola. Are you referring to item number 1, or are you referring to item number 2? But let me finish first the assessment findings. Petechiae-independent areas. 2, epistaxis. 3, hemarthrosis. C, ecchymosis at sites at minor trauma. 5, heavy bleeding after minor cuts. 6, hemoptysis. 7, intracranial hemorrhage when platelet count is extremely low. 8, hematomas from minor injuries. 9, bleeding into the gastrointestinal tract. And 10, heavy bleeding into muscle tissues. Okay. We got answers from Marie Fleur, Miss Flynn, AGI TV, Adiola. I'm still waiting for your response regarding your comment here. Please kindly explain more on number 8. Wow. Okay, let me know. Number 1 question. All right, let me go back to that after this. Okay. So let's go through the following assessment findings. The RN must determine whether the following manifestations are expected or not expected in this condition. We are talking about thrombocytopenia. All right. So let's go through the items. Excuse me. Petechiae-independent areas. Well, what do you think? Remember that petechiae are those small red and purple spots that will be caused by bleeding when they're under the skin, right? They're commonly seen in the dependent areas in thrombocytopenia. So this is going to be an expected finding. Woohoo! You got one correct answer here. Very good. What about number 2? Epistaxis, nose bleeding. What do you think about nosebleeds? Will this be an expected finding in a patient with their thrombocytopenia? Yeah, because it is one of those mucosal bleeding. So this is an expected finding here, a typical finding in thrombocytopenia. What about number 3? Hemarthrosis. What is hemarthrosis? Let me check your answers. Sour and salty, all but not expected, number 3. Expected. Nijay answered also no, number 3 for the expected, unexpected 3. That's good. All right. So, hemarthrosis, what is that? Hemarthrosis are actually those bleeding in the joints, especially in those patients with hemophilia. Joint bleeding, which is common in hemophilia. And this is not a expected finding in thrombocytopenia, so we're going to mark that as not expected. All right? Hemarthrosis, joint bleeding, is common in the what? Hemophilia disorders. They have a different problem. It's in the coagulation, not about the platelets. All right? So this is going to be not expected. What about number 4? Ecchymosis at sites of minor trauma. Remember that those are bruises which are larger, and they can easily be seen in those sites of minor trauma, or let's say in those patients with thrombocytopenia. So this is going to be assigned to the expected finding. What about number 5? Heavy bleeding after minor cuts. What do you think about that one? Well, heavy bleeding or prolonged bleeding will be assigned to expected, because when they're gonna have that small cut, their bleeding time will be prolonged even with that very small cut, right? Like I've said. And that's because of the platelet count that is low. Heavy bleeding after minor cuts. Now, number 6, hemoptysis, coughing of blood. It is also expected in thrombocytopenia. This is considered as a mucosal bleeding. Whoops. Now, what about intracranial hemorrhage when platelet count is extremely low? This is where I said something earlier about I'm not going to do it now. I'll reveal it later. Yes, this is expected, guys. Intracranial hemorrhage is going to occur when there is extremely low thrombocytes. This can be life-threatening for this patient, especially when their platelet count drops below 10,000 per cubic millimeter. Okay, intracranial hemorrhage. What about number 8? Hematomas from minor injuries. What did I say earlier? Hematomas. This is different, guys. Hematoma. It's not similar to ecchymosis. Well, if we are talking about hematomas, these are now large collections of blood within the tissues. All right? Collection of blood, large collection of blood under the tissues. And this is not expected in thrombocytopenia, but is more typical with the coagulation disorder. So this is going to be not expected. Now, bleeding into the GI tract. This is considered as a mucosal bleeding, and this is a common manifestation in the thrombocytopenia. So that will fall under the expected column. Now here, heavy bleeding into the muscle tissues. Quite similar with the hematoma. It is going to be seen in the coagulation disorders, not platelet disorder. So we're going to assign this to not expected. Okay. All right. I hope that you're able to answer the majority of the items correctly. Let me check your answers. So take note of the words heavy bleeding, hematomas, and the hemarthrosis. These are known to be present in the coagulation disorders, not in thrombocytopenia. Okay, when we're talking about the coagulation disorders, this will have a problem with the clotting factors and also causing a problem in the cascade in the coagulation process. So totally different, and that's why I did not plan on talking about the DIC today. We'll be talking about the DIC tomorrow because it's totally different monster. Okay, now, all righty, let's take a look into the next question. Another question. A nursing student is asked to evaluate various nursing actions in the care of a patient with thrombocytopenia. Based on the following nursing actions, the student must determine. Hey, let me go back to that question. I remember Adiola's question. Where was that question? Adiola, number 8. Yeah, he had a question. Adiola was asking about item number 8 in question number 1. So the statement here said, thrombocytopenia cannot occur during pregnancy. I believe this is your question about the number 8, right? I believe so. So this statement is wrong because the patient, especially when they're pregnant in their 3rd trimester, they have that risk to develop the thrombocytopenia, especially when they will end up with a HELP syndrome. Okay, they're going to end up bleeding. Okay, so here with the number 8, the thrombocytopenia can occur in pregnancy. And this is a condition wherein it's associated with preeclampsia or the eclampsia, such as the HELP syndrome. But we're not going to elaborate about the HELP syndrome today. We'll be talking about that in a different topic, which is basically in the maternal and child care. And so the answer here is no understanding, because the statement said cannot occur. That is false. It can occur. Now let's go into the 3rd question. What was AJ said? Did you say 9 out of 10? Wow, that's good. And AJ answered 8 out of 10. That's good. Wow. Number 3, a nursing student is asked to evaluate various nursing actions in the care of a patient with thrombocytopenia. Based on the following nursing actions, the student must determine if each action is appropriate or not appropriate. A nursing student is asked to evaluate various nursing actions in the care of a patient with thrombocytopenia. Based on the following nursing actions, the student must determine if each action is appropriate or not appropriate. Let me state those nursing actions. 1, treat the underlying cause of thrombocytopenia. 2, administer heparin to a patient with heparin-induced thrombocytopenia. 3, use a plain razor for shaving the patient. 4, perform a complete physical exam for signs of bleeding. 5, administer IV immunoglobulins to all patients with thrombocytopenia. 6, monitor pad count and amount of saturation during menses. 7, encourage the patient to engage in vigorous exercise regardless of platelet count. 8, obtain a list of current and recent medications, including over-the-counter preparations. 9, use tourniquet for routine blood draws. And 10, avoid monitoring stools and urine for blood. Miss Flynn's answer, 10, not appropriate. Of course. Let me see your answers, guys. All right. Waiting for your answers. So we are supposed to categorize the following items, whether they're appropriate or not appropriate. What happened to the rest of the guys here? I'm not seeing any more people answering. Well, let's take a look into the selections here. 3 and 10, not appropriate. Okay. All right. 8 or 10. Okay. We are here. That's good, Rotimi. Marie Fleur, you answered. Oh, you removed it. Okay. Keep answering while I'll be doing the rationalization here. What about number 1? Treat the underlying cause of thrombocytopenia. Of course, that's important, right? Again, back in our discussion about the nursing process, we need to identify the cause. We're going to assess their bleeding. We're also going to what? Treat the underlying cause. So this is an appropriate nursing action. Treat the underlying cause. What about number 2? Administer heparin to a patient with heparin-induced thrombocytopenia. You cheeky Marie Fleur, you removed your answer. Okay. All right. Mary, 2, not appropriate. 3, not appropriate. Okay. All right. Very good. Well, administering a heparin to a patient with heparin-induced thrombocytopenia is not appropriate. We're not going to do that, guys. We don't want to kill the patient. We're going to have to not administer. This is wrong. Do not administer heparin to a patient that had developed HIT. Never. Okay? So if you're going to continue administering or giving the heparin, let's say subcutaneous injection, or let's say infusion, this can worsen their condition. So make sure we are getting rid of this medication out of the way. Now, number 3, use a plain razor for shaving the patient. We know already about the bleeding tendencies, right? So straight razor or plain razors basically is not safe. Unsafe. We're going to get rid of that. This is also unsafe. So we're going to put not appropriate. For number 4, perform a complete physical exam for signs of bleeding. Well, of course, yeah. Thoroughly do that, guys. Make sure that you do your careful skin assessment, mucosal assessment, in order that you can identify those signs of bleeding. which is very critical in managing the thrombocytopenia. What about number 5? Administer IV immunoglobulins to all patients with thrombocytopenia. Let me take a look if you answered appropriate for all. Let me see if you answered appropriate for number 5. Okay. Number 5. Well, take a look into this number 5, guys. Administer IV immunoglobulin to all patients. That's a red flag. We are not going to do that, guys. The immunoglobulins are helpful in selected cases, but are not appropriate for all patients with thrombocytopenia. Okay? Not all. So this is incorrect. It's only going to be selected cases. Okay? So if it's caused by the immune system dysfunction, then possibly immunoglobulin, IVIG will be appropriate for this patient. So we are going to answer not appropriate. Now, number 6, monitor pad count and amount of saturation during menses. This is a very common nursing action in order for us to keep track in the blood loss of our patient. Okay, so we are going to check that as appropriate action. Now, what about number 7? Encourage the patient to engage in vigorous exercise regardless of the platelet count. Okay. So this is going to be what? Vigorous exercise can increase the risk of bleeding. So this is going to be assigned to not appropriate. Not supposed to. The vigorous exercise can increase their bleeding and should be restricted. Make sure that you keep this in mind, especially when the platelet count is reduced. We should control the bleeding here. We should prevent the patient from doing any vigorous exercise. Now, number 8, obtain a list of current and recent medications, including over-the-counter medications. And remember, guys, that I mentioned something about the over-the-counter preparations, those supplements that may have anticoagulant properties, right? So we want to make sure that we are screening our patient, especially with what supplements they are using. Okay, so this should be marked as what? Appropriate. Because some of these medications can exacerbate their condition, not help. So here, we're going to have to do that. Number 9, use tourniquets for routine blood draw. What do you think about that one? This is going to be not appropriate because when we are using tourniquets, when we are doing routine blood draw, this can cause further bleeding under the skin. Causes bleeding under the skin. So it is recommended not to use the tourniquet when we are doing the blood draw to the patient, especially if you're doing the venipuncture, if we really have to. So make sure that you are going to mark this as not appropriate. What about number 10? Avoid monitoring stools and urine for blood. No, this is incorrect. We should be monitoring their stools and also their urine in order for us to see if there is now involvement of their GI or, let's say, the genitourinary tract, which could be a sign that there is an internal bleeding. So we're going to put that as not applicable because the statement or the action is incorrect. Nice. Mary answered 10 out of 10. That's good. Okay. Wonderful. Garlic and ginger. Remember, yes, those are the common substances that can have anticoagulant properties. And so we need to be careful in thoroughly assessing or investigating the patient's supplements. We want to make sure that you have those kind of information. All right. That's okay, Melrose. There's still more. That's why we're here to learn, right? And there are so many concepts that are quite new to me as well. As I'm reading through new evidence-based medicine, because I'm actually using medicine books, not just nursing, because I like the explanations behind those answers. And I like to read those recent studies that are actually applied with the evidence-based practice. I like to investigate those. So I've learned something as well with this kind of test questions. Now, we're going to have to proceed with number 4. We're going to be back to the select all that apply. Which of the following conditions are classified as causes of decreased platelet production in thrombocytopenia? Select all that apply. 1, leukemia. 2, HIV infection. 3, aplastic anemia. 4, splenomegaly. 5, myelosuppressive therapy. What are your answers? Which of the following conditions are classified as causes of decreased platelet production in thrombocytopenia? Is it select all that apply? 1, leukemia. 2, HIV infection. 3, aplastic anemia. 4, splenomegaly. 5, myelosuppressive therapy. Eight out of 10 for Mary Flor. NAJ 7 out of 10. Ajax TV 8. Melrose 6 out of 10. Not bad. Not bad. Okay. All right. NAJ answered 1, 2, 3, 4. 1, 2, 3, 4. Okay, be careful, guys. Please check onto the statement here. Which of the following conditions are classified as causes of decreased platelet production? We're talking about the production, decreased production of the platelet. We're not talking about the destruction of the platelet. So you got to be careful when you're selecting the answers here. We're talking about the decreased platelet production. We're not talking about the increased destruction. Those are two different things. As I have mentioned during our first slide, there are 4 different contributory factors in the development of thrombocytopenia. So please be careful in understanding those terms. Okay, Esther had 7 out of 10. That's wonderful. Okay, so let's take a look into number 1. What is number 1? Leukemia. The leukemia is actually one of the correct answers because this is going to lead to the decreased platelet production. Decreased platelet production. So this is one of the correct answers. What about number 2? HIV infection. The HIV infection here is incorrect because the HIV actually will increase the platelet destruction. Increases platelet destruction. So please understand what the question is asking. We're asking you to identify those conditions that can decrease the platelet production, not increase the destruction. Those are different terms here. So you gotta be careful. What about number 3? Aplastic anemia. What did I say about the aplastic anemia earlier? Remember about the result in the bone marrow activity? Remember that there is suppression of the production of the platelets. So this will also decrease the platelet production. Decreases platelet production. Okay. Now, what about number 4? Splenomegaly. What do you think about that? Actually, that is not wrong. Aplastic anemia, that's not X, but that is a check mark. Sorry. So that is one of the answers, number 3. So we have answers 1, 3. What about number 4? Splenomegaly. Number 4, splenomegaly. Do you think that's one of the answers? Basically, that is one of the wrong answers here. We have the number 5, myelosuppressive therapy. What is the effect of the myelosuppression? What do you think about the myelosuppression? This is going to be what? This is going to reduce the platelet production. Okay? Myelosuppression. Reduce the platelet. We have Aquila, I'm sorry. Aquila Calais-Pyromani. Sorry, I mispronounced your name. Myelosuppressive therapy can decrease or reduce platelet production. Reduces platelet production. The splenomegaly can increase the destruction. So this is wrong. Increase destruction, rather, of platelets. So we have our answers 1, 3, and 5. These are conditions can reduce the production of the platelets, whereas the 2 and 4, these are conditions that can increase the destruction. Okay, so the body or the bone marrow is able to produce the platelets. However, the condition will now destroy the circulating platelets in the bloodstream. So those are very exact opposite. Okay, so I hope that you're learning from this test item. Number 5. A 45-year-old female patient reports experiencing manifestations of thrombocytopenia and is found to have a platelet count of 18,000 per cubic millimeter. Which of the following are clinical manifestations of thrombocytopenia? Select all that apply. A 45-year-old female patient reports experiencing manifestations of the thrombocytopenia and is found to have a platelet count of 18,000 per cubic millimeter. Which of the following are clinical manifestations of thrombocytopenia? Select all that apply. Is it 1, petechiae, 2, ecchymosis, 3, hypertension, 4, mucosal bleeding, and 5, increased appetite? Your answers. Mary answered 1, 2, 4. 1, 2, 4 from Miss Flynn. Jet de Los Santos answered 1, 2, 4. Cephas answered 1, 2, 4. That's looking good. Virtuous Lady as well. Patience answered 1, 2, 4. Melrose as well. Rudeline. AGI TV answered 2, 3, 4. Or was that a mistake for that number 2? All right, 2, 3, 4. AG Ike, just checking on you. You answered 2, 3, 4. So that's basically ecchymosis, hypertension, and mucosal bleeding. We have Amadi Mililapi. Yeah, this is the first time I've seen your name. Welcome to the class. All right, so Let's identify all these manifestations. What is petechiae? Again, those are the red, small red or purple spots that is caused by the bleeding into the skin. And this is a very common finding in patients with a platelet count in that is less than 20,000. Okay, common finding, especially if the platelet count drops below 20,000 per cubic millimeter. Oh, my M is like what? Per cubic millimeter. So that is a common finding. What about ecchymosis? Ecchymosis are what? They are the large bruises that can occur in patients with low platelet counts as well. And this is going to be caused by minor trauma, maybe bumping themselves into hard surfaces. So that is another correct finding. What about hypertension? Do you think hypertension is a common manifestation? No, it isn't. Okay, it's not known to cause high blood pressure. We are eliminating that one. What about number 4? Mucosal bleeding. What did I say earlier? Mucosal bleeding is going to be what? Manifested as the epistaxis, the bleeding gums, the GI bleed. So these are, this is going to be a common manifestation like nose bleeding. Let me write them down first. Gum bleeding and GI bleeding. These are your mucosal forms of bleeding. Okay. Thank you, Mary. Yeah, kindly please hit the like button. All right. Mucosal bleeding are those nose bleeding, gum bleeding, GI bleeding. That's a common finding in our patient with thrombocytopenia. Increased appetite. Well, should we expect increased appetite? No, it's not associated with thrombocytopenia. And it's going to be closely associated more with bleeding and bruising tendency. So we're going to eliminate that one. We're going to eliminate hypertension. So we have our answers. Options 1, 2, and what? Number 4. Petechiae, ecchymosis, and mucosal bleeding. Let's move forward with number 6. A 65-year-old male patient presents with fatigue and easy bruising. Please explain more on the hypertension. Okay. With the option of hypertension, the bleeding itself will not manifest in hypertension. There is no relationship about the superficial bleeding into the blood vessel itself, or let's say affecting the tone, the vascular tone of the, I'm talking about the blood vessel. It's not known to affect the lumen, the constriction or the vasodilation of the blood vessels. It does not. Okay, and so there is no relationship between the drop of the platelet and the hypertension. There's no relationship at all. It's not known to cause the vasoconstriction. I hope that it's gonna help you understand AGI TV. Again, the thrombocytopenia is mainly manifested as mucosal bleeding. Okay, those epistaxis, GI bleeding, the gum bleeding, skin issues like the ecchymosis, the petechiae. But if we were talking about the hypertension, that's kind of like way out of its territory. The disorder itself is not known to affect the tone of the blood vessel. It's not known to constrict the blood vessels. And so we're going to get rid of that. Okay. Number 6. A 65-year-old male patient presents with fatigue and easy bruising. Welcome, Mercy Daka. Welcome, Narjisa. Oh, no. No blood production will expand the vessel. No, there's nothing like that. Well, thank you for the question, though. Question number 6. A 65-year-old male patient presents with fatigue and easy bruising. Lab results reveal, or lab tests reveal, a platelet count of 25,000 cubic millimeter. Which of the following lab tests, or finding rather, would be expected in this patient with thrombocytopenia? Select all that apply. Is it 1, decreased hemoglobin, 2, prolonged prothrombin time, 3, prolonged partial thromboplastin time, and 4, positive platelet aggregation test for heparin-dependent antibodies, and 5, increased red blood cell count. Okay. The question states, a 65-year-old male patient presents with fatigue and easy bruising. Lab tests reveal a platelet count of 25,000 per cubic millimeter. Which of the following lab findings would be expected in this patient with thrombocytopenia? Select all that apply. Is it 1, decreased hemoglobin, 2, prolonged prothrombin time, 3, prolonged partial thromboplastin time, 4, positive platelet aggregation test for heparin-dependent antibodies, and 5, increased red blood cell count? So we are going to look for those lab findings that would be expected in a patient with thrombocytopenia. We have answers 234, 235, 2324, 234. Okay. Guys, there is already easy bruising. That's already a sign of bleeding. So don't neglect looking into the entirety of the lab test. Okay? Your complete blood count, you should look into the red blood cell count, the hemoglobin, the hematocrit, and also the platelet count. So do not neglect the hemoglobin. So the correct answers here are the following. Answers are number 1, number 2, number 3, and what? Number 4. Those are the correct answers. 1, 2, 3, and 4. Take a look into the easy bruising. That is already a sign of. This is a sign of, what do you call this? Bleeding already. There is a reduction of the blood to the red blood cell, hemoglobin. So you're going to expect that number 1 to go down. Hemoglobin can decrease because of what? Possible chronic bleeding. Okay. Now, what about number 2? Prolonged prothrombin time. What do you think about the PT? It can be decreased as well, or actually it will be increased. The time will be prolonged because what's going to happen is that the thrombocytopenia itself can also impair the clotting process. So there will be an increase in the PT. Okay. What about number 3? Prolonged partial thromboplastin time. What do you think about that? Well, the thrombocytopenia can also affect the intrinsic pathway of the coagulation. So there will be a possibility of a prolongation of the PTT. Okay. And number 4, positive platelet aggregation test. What do you think can be seen or what will be revealed with this testing? Positive platelet aggregation. So this can now what? The platelets, where the low platelet count can now prolong the time required to clot. Or this is going to, actually this is going to be a complication related to the HIT. So our patient here will have that testing it will turn out positive. Okay, it will be positive for this patient, especially in a case of HIT, heparin-induced thrombocytopenia. Now, what about number 5? Increase red blood cell count. When you have a thrombocytopenia patient, I don't think so there will be an elevation of the red blood cell. It will be the exact opposite. There will be a reduction of the red blood cell level in the body. Okay, so no elevation of the red blood cell. Now let's move on to the next. Number 7, a 60-year-old male patient admitted to the med-surg unit for post-operative care is receiving subcutaneous heparin injections for deep vein thrombosis prophylaxis. On the 5th day, post-surgery, he develops sudden bruising and gum bleeding. Laboratory tests reveal a platelet count of 20,000 per cubic millimeter. Which of the following interventions should be performed in managing his condition? Select all that apply. The situation stated, a 60-year-old male patient admitted to the medical surgical unit for post-operative care is receiving subcutaneous heparin injections for deep vein thrombosis prophylaxis. On the 5th day post-surgery, he develops sudden bruising and gum bleeding. Laboratory tests reveal a platelet count of 20,000 mm³. Which of the following interventions should be performed in managing his condition? Select all that apply. Is it 1, discontinue heparin? 2, administer platelet transfusions. 3, administer argatroban as prescribed. 4, continue heparin at a lower dose. 5, monitor for venous and arterial thrombosis. I'm seeing 1-5 from Nijay. Marie-Flore answered 1-5. Remember about the HIT. So the situation stated that the patient has received subcutaneous heparin injection for DVT, but on the 5th day post-op, he develops sudden bruising and gum bleeding, and the platelet count is 20,000. What do you think is this complication? Remember about the HIT that I said earlier? The heparin-induced thrombocytopenia. Don't forget about the treatment that we talk about. All right, so I'm seeing 1-2-5, 1-3-5, 1-5, 1-3-5. Let's go through the selections here, guys. All right, don't worry if you are committing any errors today. That is totally fine. That is totally fine. This is quite a complex concept, and we really need to break this down. So, what about number 1, discontinue heparin? This is a correct intervention because our platelet drop was caused by, correct. Oh boy. That is correct, not caressed. The platelet drop is caused by the heparin that was part of the treatment for the DVT. So this is what we have as the HIT, heparin-induced thrombocytopenia. Okay, so again, with the HIT, remember what I said earlier, that this is caused by immune-mediated reaction. Immune-mediated reaction. And there is now the formation of the antibodies. The body will be developing the antibodies and will now recognize the heparin-bound platelet factor. Let me slowly do this. Recognize the heparin-bound platelet factor which is known as the PF4. Now we're getting fancy this time. Again, the HIT is a immune-mediated reaction wherein it can lead to the development of formation of the antibodies that will recognize the heparin-bound factor, which is the PF4. Now, what can happen here is that it will now activate the platelets. So even though there is a drop in the platelets amidst this kind of like immune-mediated reaction, it will now activate the platelet and it will now cause massive thrombosis. So what we need to do here is to really stop the infusion, okay? And we are not going to add more heparin because it will just worsen the thrombosis. Okay, that's kind of weird, right? Hey, the patient has thrombocytopenia, but why they're going to end up with thrombosis? Like I've said earlier, that immune-mediated reaction, the development of these antibodies will now lead to platelet activation. Okay, when this happens, there will be increasing risk of thrombosis. So our goal here is to discontinue giving them the heparin. All right. So we are going to do that. Now, what about number 2? Administer platelet transfusions. What did I say about the platelet transfusion earlier? Remember that when we are going to give them platelets, this is incorrect. Incorrect. We're not supposed to give them platelets during the HIT because they can exacerbate thrombosis. It can exacerbate thrombosis. It will trigger further platelet activation. So not required. So we're not going to administer any platelet blood product to this patient with a HIT. Okay? Now, what about number 3, administer argatroban. So this is a medication that will become a alternative anticoagulant. And so the patient will possibly receive this medication as an alternative anticoagulant because they develop antibodies to the heparin. So this is going to be a correct answer. Okay? Argatroban. So this is going to be used instead of the heparin. This is what we call as the direct thrombin inhibitor. Argatroban. The direct thrombin inhibitor. And I'd encountered this kind of case way back early in about the year 2005. We were giving heparin infusion for this patient that had DVT. But eventually, about like 6 days after the infusion, the patient developed the HIT, and so we ended up replacing that with argatroban instead. Okay, so this is an expected alternative treatment to replace the heparin. It is going to also reduce the risk of thrombosis. Okay, so that's one of the correct answers. What about continue heparin at a lower dose? We're not going to give anymore. Like I've said earlier, once the patient develops the antibodies against the medication, we're gonna stop administering them any heparin, not even in the near future, not even flushing their central line with a heparin to prevent any clotting. No more of that medication. We're not going to give any more heparin in the future. And so that is going to be eliminated. Correct. This is correct. Number 3 is correct. Administer argatroban. Number 4, continue heparin at a lower dose. That is wrong. This is wrong as well. Number 2 is wrong. Number 4 is wrong. Monitor for venous and arterial thrombosis. What do you think about that? Is that going to be one of the interventions? Yes. Remember that the patient with HIT, they are at higher risk to develop the thrombotic events. So make sure you include this one. Monitor for venous and arterial thrombosis. Okay. So our correct answers are 1, 3, and 5. Yeah, I'm seeing you guys answering 1, 3, 5. That's a good sign. Wonderful. Now, number 7, or number 8 rather. A 45-year-old female patient presents with easy bruising and petechiae. She reports feeling fatigue and notices bruises appearing without injury. Which diagnostic evaluations are appropriate for confirming idiopathic thrombocytopenic purpura? Select all that apply. A 45-year-old female patient presents with easy bruising and petechiae. She reports, question, can one administer warfarin? The warfarin actually will not be included in the treatment, especially with this kind of, if you're talking about the, like the urgency in preventing the thrombotic events, the warfarin can work very slowly. And so that will not be one of the major anticoagulant medications, especially when we are dealing with the DVT. Maybe at a later time, but not during the acute phase. Okay. Yeah, so that's the reason why we're not going to look forward to getting or administering the warfarin therapy in replacement of the heparin during the acute phase, because the medication works slowly. It will take good 2 to 3 days before it can even start working. Okay, and so the argatroban is the direct thrombin inhibitor would be the best option as a replacement to the heparin. Okay, number 8. I hope that I answered your question, NJ. 45-year-old female patient presents with easy bruising and petechiae. She reports feeling fatigue and notices bruises appearing without injury. Which diagnostic evaluations are appropriate for confirming idiopathic thrombocytopenic purpura? Select all that apply. 1, CBC with platelet count. 2, bone marrow aspirate. 3, testing for Helicobacter pylori. 4, MRI scan. 5, bleeding time test. So I'm seeing 1, 5, 1, 2, 5, 1, 5. Okay, let's reveal the answers. We'll start with number 1, CBC with platelet count. Remember about the complete blood count, it can reveal the hemoglobin, platelet, or red blood cell, hematocrit. And so this will be helpful in what? It will be helpful in determining if there is now a reduction in the platelet count and also the hemoglobin count. So this is one of our correct answers. Correct. What about number 2? Bone marrow aspirate. What is that? Bone marrow aspirate is also correct. Let me just put it this way. Correct. And the reason for that is because the bone marrow will be able to assess increased megakaryocytes. Will assess increase in megakaryocytes, those immature platelets, right? Which is going to be the characteristic of the ITP. So this is one of the diagnostic tests. What about number 3? Testing for Helicobacter pylori. What is that testing? Remember that a patient that has a positive H. pylori has that tendency to have what? A link to the development of ITP. So this is another correct answer. And we need to really treat this patient. with the antibiotics that will target the H. pylori in order to allow improvement of the platelet counts in this patient. It's an immune kind of a reaction that is going on when there is a H. pylori infection. What about number 4? MRI scan. Will the MRI scan a diagnostic tool to help determine the ITP? No, it is not a standard tool in the diagnosis. What we usually will use are what? The platelet count, the bone marrow. MRI will not do that. It's not a standard diagnostic tool. Okay, so we're gonna mark that as X. What about bleeding time test? Do you think it will be a correct answer for bleeding time test? Yeah, it is correct. This will be one of the correct answers here, bleeding time. As we know that the patient will have prolongation in their bleeding time as well. Okay. So that would be the correct answer. So we are going to answer 1, 2, 3, and 5. Except 4. All right, moving on to the next item, number 9. Ooh, there you go again. We're back to the matrix. Okay. A 35-year-old female patient presents to the ED with petechiae, ecchymosis, and gum bleeding. She reports feeling fatigued and experiencing heavy menstrual bleeding recently. Laboratory tests reveal a platelet count of 15,000 per cubic millimeter. And based on the treatment options for immune thrombocytopenic purpura, identify which interventions are appropriate and which are not, or expected or not expected. Select the column right here for those interventions. So we're gonna put expected or not expected. So 1, glucocorticoids administration. 2, IVIG. 3, splenectomy. 4, rituximab. 5, platelet administration. 6, intravenous antibiotics. 7, anticoagulant therapy. 8, bone marrow transplantation. 9, NSAIDs. 10, physical therapy to improve platelet function, or platelet count rather. What do you think? A 35-year-old female patient presents to the ED with petechiae, ecchymosis, gum bleeding, fatigue, heavy menstrual bleeding. Lab tests reveal platelet count of 15,000 per cubic millimeter. Which of the following interventions are expected and which are not expected? All right, still waiting for your answers. One, two, three. Okay. So let's take a look into option number 1, administration of glucocorticoids. Remember that we are going to expect the prednisone, right, as one of the treatment modalities. This is going to suppress the immune response against the platelets in order to what? Increase the platelet count. So we are going to expect administration of what? Prednisone. And the reason for that, again, is to suppress immune response. Okay. And the expectation here is to allow the elevation of the platelet count and also reduce the bleeding risk. So this is going to be expected. What about number 2? IVIG administration. What is that? Remember about the IVIG? It will work by what? Saturating the reticuloendothelial system. It will prevent the destruction of the platelets coated with the autoantibodies. It will prevent destruction of platelets. So this is going to be unexpected therapy. So that is going to be checked off here. What about splenectomy? Splenectomy is that surgical removal of the spleen. This is going to be indicated for chronic steroid-resistant induced idiopathic thrombocytopenic purpura. So this is going to be expected as well. What about number 4, administration of rituximab? This is a medication that is going to target the cells responsible for producing the antibodies against the platelets. Let me erase this so I have room to write on. The rituximab is a monoclonal antibodies, right? So this is a monoclonal antibody that will target that specific protein. Monoclonal antibody therapy that will target the B cells. It targets the B cells that is attacking the platelet. So this is going to be an expected treatment. What about administration of platelet transfusions? Are we going to administer platelet in this patient? We're not talking anymore about HIT this time. Okay, so we are going to administer platelet transfusion this time. This is going to manage acute bleeding, okay? To manage acute bleeding. And our goal here is to elevate the platelet count quickly and prevent severe hemorrhage. Now, what about number 6? Do you think that we're supposed to be administering the antibiotic for the patient? Administration of antibiotics. Administration of antibiotic number 6. You sure? Are we supposed to do that, guys? Is that part of the treatment for the ITP? Did we mention about the antibiotic treatment? Yes. Okay. If there is an infection going on caused by the what? H. pylori, then we are going to administer the IV antibiotics. Remember about the H. pylori? Remember about the H. pylori, guys. I just want to make sure that you are reviewing. H. pylori. H. pylori infection. And remember that it can cause that immune response that can now destroy the platelet. So if there is a positive H. pylori infection, then we are going to treat the patient with the IV antibiotics. Yeah. So this is going to be expected as well. Administration of antibiotics. Now, what about number 7, administration of anticoagulant? Are we supposed to do that in ITP? Are we supposed to give them an anticoagulant therapy when they have an ITP? Well, we know for sure that if we are going to continue giving them the anticoagulants, their bleeding will now be what? Worse. They are contraindicated. We're talking about the ITP guys, not heparin-induced thrombocytopenia. ITP, no anticoagulants this time. So the patient's platelet count is already low and we want to control the bleeding. We don't want any more anticoagulants. No argatroban here because the argatroban is only indicated for that thrombocytopenia, the heparin-induced thrombocytopenia. So it's not indicated in this case. All right. We're totally talking a very different scenario. We're talking about ITP. Now, bone marrow transplantation. What do you think is your answer here about the bone marrow transplantation? Well, the bone marrow transplantation is such an extreme kind of a measure, okay? But this is not going to be indicated this time, all right? This is only intended when the patient has that severe form or severe case of ITP, that they are not responsive to the standard treatments. And so we are not going to include this right now. It's not going to be expected at the moment. So this will be not expected. All right. What about administration of NSAIDs? Guys, remember about the NSAIDs effect. It will inhibit platelet function. Inhibit platelet function. And so we are going to assign this as what? Not expected as well. Now, physical therapy to improve platelet count. Do you think that physical therapy can increase the production of the platelet? No. This will not influence the production of the platelet, so we're going to put that under not expected. Okay. So we have the following answers for the expected: administer glucocorticoids, IV immunoglobulin, splenectomy, administration of rituximab, administration of platelets, administration of antibiotic, especially if there is that H. pylori, and also administration of antibiotics. That's the last one. However, the rest of the answers are going to be assigned under not expected. Let's move forward to the next item here, number 10. A 55-year-old male with chronic ITP is receiving education about managing his condition. Which patient condition points are essential to reduce bleeding risk? Select all that apply. The question states a 55-year-old male with chronic ITP is receiving education about managing his condition. Which patient education points are essential to reduce bleeding risk? Select all that apply. Is it 1, avoid alcohol consumption, 2, engage in regular strenuous exercise, 3, report any new or unusual bleeding immediately, 4, avoid flossing, 5, maintain regular dental checkups? We're talking about ITP. Receiving education about managing his condition. Okay. 6/10, 7 out of 10. Not bad. That's not bad. And remember, guys, that would not be, if you're committing an error on one of the columns, that will not be deducted with that kind of test item. But if that test item is asking you to assign that intervention, whether it can be, that's totally a different test item. I was thinking of something else, but anyway, disregard what I just said. Okay, number 10. A 55-year-old male with chronic ITP is receiving education about managing his condition. Which statement or which patient education points are essential to reduce the bleeding risk? Select all that apply. So we have answers 1, 3, 4, 5, 3, 4, 5, 1, 2, 3, 4, 5. Okay, let's take a look. Avoid alcohol consumption. Do you think that would be essential in reducing the bleeding risk? Avoid alcohol consumption? Yeah, that is correct, because we know that alcohol can impair the platelet function. It can increase the risk of bleeding, especially for those patients with ITP. Now, what about number 2? Engage in regular strenuous exercise. Are we supposed to educate the patient about strenuous exercise, regular strenuous exercise? Of course not. This is going to be unsafe for the patient, so we are eliminating this one. Unsafe. This is already a keyword, guys. Anything that could be causing overexhaustion into our patient, injury to our patient, you're going to get rid of that one. So this is wrong. This isn't safe to the patient, especially for the one with thrombocytopenia. They should avoid that one. Number 3, report any unusual bleeding immediately. Of course, we are going to encourage the patient to promptly let the doctor know if there is now going to be new signs and symptoms of bleeding immediately. So that is one of the correct answers. What about number 3? Use floss gently or avoid flossing. Select all that apply. Yes, the gentle dental care will help prevent the gum bleeding, which can become problematic in patients. So gentle flossing can be acceptable, guys. So we will be encouraging this one. Okay. And also what? Report any unusual bleeding. That's also correct. What about maintain regular dental checkups? What do you think about that? Well, this will help monitor the oral health of the patient, and it will also detect early signs of bleeding issues so that we can manage the condition early on. This is also correct. So we have answers 1, 3, 4, and 5. Okay. Moving on to the next question, number 11. Are you still okay? A 25-year-old male with a recent diagnosis of immune thrombocytopenic purpura is receiving outpatient care. Which follow-up care and lifestyle modifications should the nurse emphasize to the patient? Select all that apply. Is it 1, routine follow-up for platelet counts? 2, avoid activities that carry a high risk of injury? 3, regular use of over-the-counter herbal supplements? 4, maintain a balanced diet with adequate nutrition? And 5, use of stool softeners as needed. Here we are being asked about ITP. A 25-year-old male with a recent diagnosis of ITP is receiving outpatient care. Which of the following follow-up care and lifestyle modifications should be emphasized by the nurse? Let me check your answers. I'm not seeing it yet. Is it routine follow-up for platelet counts? Or 2, avoid activities that carry high risk of injury? Or 3, regular use of over-the-counter supplements, herbal supplements? 4, maintain a balanced diet with adequate nutrition. I'm seeing from Jet 1, 2, 4, 5. That is the correct. Those are the correct answers. Okay. Answers are 1, 2, 4, and 5. Routine follow-up for platelet counts is very important, so we will know for sure if the platelet counts is improving or if it's not. Okay, or there is now disease progression of the ITP, then it will reveal that maybe the platelet count will be a lot lower. So this will be one of the correct answers. And then avoid activities that carry a high risk for injury. Of course, if that's already identified that will be unsafe for the patient, then we'll do that as well. Regular use of over-the-counter herbal supplements, this is wrong. Remember about herbal supplements that can potentially possess those anticoagulant drug effects. So we are going to avoid or educate the patient to avoid those things. You got your ginger, garlic, the ginkgo. What else? Ginseng, yeah. Ginger, garlic, and ginkgo. So be careful with those. We are eliminating that one. Number 4, maintain a balanced diet, adequate nutrition. Of course, never eliminate that one. What about number 5? Use of stool softeners. This is very important, especially for those patients that have chronic constipation. We are going to encourage the intake of, ginseng. That's correct. Thank you, virtuous lady. So we're going to encourage the use of the stool softeners in order to prevent constipation and to prevent straining. This is also correct. To prevent rectal bleeding. Especially for those patients that have a pre-existing hemorrhoids, right? Yeah, we need to address that. 1, 2, 4, 5. Let's move on to number 12. A patient receiving IV heparin and oral warfarin for deep vein thrombosis is diagnosed with heparin-induced thrombocytopenia, HIT. When the platelet count drops to 110,000 microliter, what action should the nurse include in the care plan? Is A, or 1, prepare for platelet transfusion. 2, discontinue the heparin infusion. 3, administer prescribed warfarin or Coumadin. 4, use low molecular weight heparin. What is your answer? A patient receiving IV heparin and oral warfarin for deep vein thrombosis is diagnosed with heparin-induced thrombocytopenia when the platelet count drops to 110,000 per microliter. What action should the nurse include in the plan of care? Is it 1, prepare for platelet transfusion? 2, discontinue the heparin infusion? 3, administer prescribed warfarin, Coumadin? Or 4, use low molecular weight heparin? I'm seeing 2s. That's a good sign. Very good. That is the correct answer. We're talking about the HIT, heparin-induced thrombocytopenia. So our correct answer here, guys, is to discontinue the heparin infusion. If it is a subcutaneous, the same thing. We're going to have to discontinue the sub-Q injections of a heparin 5,000 units every 8 hours, notify the medical provider about it in order to make it as an official order. So when we have a patient that has a diagnosis of HIT, make sure you do this one all the time. There's no replacement. We're not even going to attempt this one. The low molecular weight heparin, no, not even. Prepare for platelet transfusion. Are we supposed to give them platelet? Remember, it's not going to be effective, guys. This will worsen the HIT. Will worsen the HIT. No platelet transfusion. This is wrong. What about number 3? Administer prescribed warfarin or Coumadin. Are we going to continue that one? We are going to delay this one, guys. So, administration of warfarin, once the patient is diagnosed with HIT, we're going to halt this one. Halt the administration of the warfarin up until their platelet count will be safer, okay? So this will be stopped or momentarily discontinued for the time being. And we will have to wait from the medical provider's decision. Maybe they want to reinstitute the Coumadin once the platelet count is more stable. Will be resumed possibly when the platelet count is more stable. So there you go. We're gonna get rid of number 3 as well. What about number 4? Use of low molecular weight heparin. It's gonna be discarded. We don't want that either. So we are done with this question. Our answer is discontinue heparin infusion. Number 13, which lab result is expected to decrease if a patient develops HIT? Is it prothrombin time? Is it 2, erythrocyte count? Or 3, fibrinogen degradation products? Or 4, activated partial thromboplastin time? What do you think? Argatroban, yes. Or the direct thrombin inhibitor. Yeah. So your answer here, guys, what's the answer? This question is quite complex, to be honest. So the rationale for this test question is kind of like gonna blow your mind because of the mechanism involved, the immune-mediated response in the body. So, which lab result is expected to decrease if a patient develops heparin-induced thrombocytopenia? We're not talking about the regular scenario that we are just giving heparin infusion and then we're checking the activated partial thromboplastin time. No, that's out of the picture right now. We're actually talking about HIT. So, what would be the answer here, guys? The correct answer for this situation is letter D, or number 4. Activated partial thromboplastin time. Let me explain. The reason why it's going to be the answer, why there is a decrease in the APTT. Decreased APTT. The reason because of the clumping of the platelets. Remember about the thrombotic events? Clumping of platelets. It's because of the immune response. The antibodies will now stimulate the platelet. This will lead to the thrombotic event. So there will be now clumping of the platelets, which is going to reduce the effectiveness of the heparin. It will now reduce the effectiveness of heparin. That alone, guys, can make the anticoagulation very difficult, okay? And so the result here, because the platelet they're clumping all together, the heparin will no longer be able to prevent the clot formation. This will now really require higher doses, but it doesn't mean that higher doses can treat. It will just worsen the situation, okay? So if we are gonna attempt to give them the heparin because it's calling for a higher heparin dosage, no, it's just gonna make things worse. It will just lead to some more activation of the platelets. There will be more thrombotic events that can happen. So here what you're going to see is the decrease in the activation, a decreased APTT. Okay. It's no longer effective. And so the APTT level is going to be decreased this time. This is what we were looking for. Now take a look into number 1, prothrombin time. Why is prothrombin time is wrong? Well, we know that the PT is going to measure how quickly the blood clots, but this is not going to be typically affected by HIT. Not affected by HIT, right? It's not expected. What about erythrocyte count? Well, we know that the RBC count is going to reflect the number of the red blood cells, right, in the blood, but it's not going to be directly affected by HIT as well. Not directly affected by HIT. Now, what about the fibrinogen degradation products? What do you think about that one? What we know about the fibrinogen degradation products, they are the markers that can show how quickly the blood clots break down, but the HIT doesn't usually change the marker, so they're not going to be expected to decrease in HIT. Again, let me explain, but I need to get rid of this. I need more room. Number 3, again, fibrinogen degradation products. These are going to be the markers, supposedly. They are considered to be the markers that will show how quickly the blood clots break down. But remember, guys, with thrombotic events, this will not be changed because there's no breaking down. There is now more of the thrombotic events. So they're not going to be expected to be decreased. Okay? All right. I hope that you were getting the explanation regarding the other 3 tests. Moving on to number 14. A 65-year-old female patient with thrombocytopenia presents to the ED. Which assessment finding should the nurse communicate immediately to the healthcare provider? Is it 1, platelet count is 52,000 microliter? 2, the patient is difficult to arouse? 3, there are purpura on the oral mucosa? 4, there are large bruises on the patient's back. Again, the patient is a 65-year-old female patient with thrombocytopenia, presents to the ED. Which assessment finding should the nurse communicate immediately to the healthcare provider? Is it 1, platelet count is 52,000 per microliter? And 2, patient is difficult to arouse? 3, the purpura, there are purpura on the oral mucosa? And D, there are large bruises on the patient's back. What do you think would be the most important assessment finding here? Critical assessment finding. I'm seeing 1, 3, 4, 1, 2, 2. So I really want you to keep an eye here. Which of the following manifestations could mean a much worse manifestation? Look for, or the worst rather, worst sign of bleeding. This is what we are looking for. A 52,000 platelet count per microliter, even though it's very low, right? But does it mean anything to you? Are there any more manifestations associated with it? So if you're just looking into the number, yeah, it can be critical, but what about the manifestations in the other choices? Do you think that the other choices here are much more pressing? Yeah, the correct answer here is number 2. Patient is difficult to arouse. That is our assessment finding that we should report to the patient. This could mean that the patient is having cerebral bleeding. Okay? Difficulty in waking up the patient could mean cerebral bleed, and this is a life-threatening, very serious complication of thrombocytopenia. 4 may be due to abuse. There are large bruises on the patient's back. Large bruises could mean anything. Remember that when we are talking about possible elder abuse, we have to investigate further about the discoloration of the skin. It will be more of like different stages of healing, right? And so if you answered number 4, it's not going to be consistent with elder abuse. Yeah, no, there are bruises, right? But we need to investigate further about this one. Needs further investigation if we are thinking about elder abuse. Again, that's a possibility, but again, we need to more of the and to investigate more assessment findings. So, number 2, the patient is difficult to arouse if there is now a change in the level of consciousness. LOC. Change in LOC is one of those critical assessment findings. If the patient has been noted to have a change in the LOC, then that is significant. We need to act on it, make sure that we are going to prioritize this assessment finding. This could be directly associated with cerebral bleed. Guys, do not forget about LOC. And so, in your clinical practice, don't ever neglect doing the Glasgow Coma Scale, GCS. Remember about the GCS, perfect score of 15? Even if you're just stepping inside the patient's cubicle or room. Let's say, for example, the patient may be kind of like closing their eyes, and then once they hear you stepping into their room, they're going to open up their eyes. You can already start assessing their Glasgow Coma Scale just by that, the eye opening, without even telling them, hey, my name is so. You can actually now start checking their level of consciousness just by that, okay? And then you're going to have to go through with the rest, the motor response, the verbal response. You can directly get a complete data of your GCS just by that, okay? Don't neglect that one. Always start with a neurofunction. You can just do this by just with the initial interaction with your patient, okay? You can find out if they're confused or disoriented. Yeah, always prioritize the neurofunction, guys. 3, there are purpura on the oral mucosa. Will that really call for an immediate notification to the doctor if there is presence of purpura? These are going to be expected finding, guys. So there's not really a need for us to immediately notify the doctor. It's not life-threatening. So this is expected, not life-threatening. Okay. But we can document this one that you noted purpura on the oral mucosa. And if you had answered number 4, there are large bruises on the patient's back. This is also an expected manifestation. Large bruises. And you can document this one. You can monitor, but it doesn't really call for an immediate notification to the medical provider. And so, guys, don't forget about prioritizing what is urgent, what is life-threatening, and what can wait. Okay? Do not forget to prioritize the manifestations. Moving on to number 15, and I believe this is the last, not quite. A 60-year-old male client underwent coronary artery bypass graft surgery 3 days ago. Which condition should the nurse suspect when the client's platelet count decreases from 240,000 per microliter to 6,000 microliter? Okay, the question states, a 60-year-old male client underwent coronary artery bypass graft surgery 3 days ago. Which condition should the nurse suspect when the client's platelet count decreases from 240,000 microliter to 6,000 per microliter? Is it 1, bone marrow suppression, 2, immune thrombocytopenic purpura, 3, disseminated intravascular coagulation, and 4, heparin-induced thrombocytopenia and thrombosis? Okay, I'm waiting for your answers. And thank you, Jet de Los Santos, for your comment. Decreased level of consciousness is concerning. Very good. Probable stroke or cranial bleeding, Mary, thank you for that. And Deep, also with your suggestion, maybe due to abuse. It will require investigation too. So, our case here is on a patient that had CABG 3 days ago. So which condition should the nurse suspect when the client's platelet count decreased from 240,000 to 6,000 per microliter? So this is a multiple choice, guys. It's not select all that applies. So you're only allowed to select one choice. What would be that? I'm seeing 44125. Maybe some of you guys are answering still from the previous test question, so maybe that's the reason. But I'm seeing 4, which is heparin-induced thrombocytopenia and thrombosis. That is the correct answer. 4. The reason why this is the reason, it's because in a CABG surgery, the coronary artery bypass graft, the patient will often receive heparin to prevent blood clots. In CABG, patient receives heparin to prevent blood clots. And we know that this can lead to that possible reaction. It can lead to the development of the formation of the antibodies. And so the antibodies now will attack the platelet. It can now lead to the formation of, or let's say the autoantibodies will now stimulate or it will now activate more platelet, which will lead into the formation of more clots. Thrombotic events, right? So that is the rationale, guys. And this will really require us to quickly assess, make sure that we have reviewed the medications that the patient is taking, and we want to make sure that this is reported immediately to the medical provider so that we can discontinue giving them the heparin. And if there's still a need for us to anticoagulate the patient, they might need to get the alternative medication, the argatroban, if they have some DVT going on, then make sure that we are monitoring for any more thrombotic events. Okay, so I hope that you are able to understand really the reasoning in HIT that we're not supposed to give platelet transfusion. No platelet transfusion in HIT. I hope that you were able to digest that, because this was actually a very complex topic, and I hope that you're able to retain this in your subconscious and trying really my best here to make it more digestible for you guys. All right. How's everyone doing right now? Are you still awake? Are you still breathing? Or do you need the Argatroban? Just kidding. Again, we are inviting you to enroll in our NCLEX RN course at our website. Make sure that you check out our website at www.stancoastnclexcoaching.com. We are offering that course for the entire 6 months. With your subscription, you will have access to the on-demand videos, the animated videos that will be useful during your downtime. We really want to make sure that you have that confidence before taking that exam. All right. And we're hoping that you're going to end up with flying colors and become a registered nurse in the US. So thank you so much about today. Thank you for your attendance and your participation. And tomorrow we will be talking about DIC, the disseminated intravascular coagulation and other problems in coagulation. So get ready with your questions tomorrow. If you have any doubts or any clarifications, make sure that you put that in the comment section so we will be able to answer those in the timely manner. So that's it for today. Again, thank you and stay safe, everyone. I'll see you tomorrow at 9 p.m. Eastern Standard Time. Thank you and have a great the rest of the day. Bye-bye.